Welcome to another Straight Talk. Today I have the honor to speak with Dr. Rafif Tayara from Dubai. She is a pediatric dentist, entrepreneur, and author of the book Dr. Smile. So it's a huge honor for me to have you here today because I think you as a pediatric dentist, you play a very crucial role in prevention of seeing these children as early as you do and to actually bring them into the right direction where they should be considering breathing, chewing, swallowing, and tooth crowding. So, Rafi, thank you so much for accepting your invitation. So let's get going. So tell me, what is your story? How did you actually get into this topic of doing early prevention? And you're doing now also a lot of aligners with orthodontics. So how come that you as a pediatric dentist actually, you were not scared of doing it? What happened?
Yeah. Well, first of all, thank you so much for having me as a guest in your YouTube channel and in your sessions, the Straight Talk. I'm very happy we're having this talk because I feel it's so much needed in the world of of early orthodontics care and dentistry today. Actually, I had an interesting journey entering pediatric dentistry because as a dentist, I didn't start by liking the world of dentistry, and then when I had a rotation at a children's hospital one day, I felt that I kind of found my call because I was very inspired by how you can treat a child very early, and then you can, do a lot of things by, kind of tackling their psychology and their phobia. So that's what really got me in pediatric dentistry. And then through my career in pediatric dentistry, I found very fascinating the world of early orthodontics and early correction in the face, because I started seeing here in the region of the Middle East and the GCC, I started seeing a lot of anterior crossbites and early class 3 that are very related to genetics in certain families in the whole GCC region. There are, you see like huge families that they all have. So I started seeing the little children, they used to come, at 2 years, at 3 years, at 1 year to me. And I started seeing those tendencies and ending up with anterior crossbites. And this is how I started designing my own fixed appliances and, techniques and researching how can I do this. Same thing went to cavities because I started really investigating what are the deep root causes of cavities in children and oral diseases, and I started digging into that. It's not just about sweets or diet, but there's a lot of other factors, as like the iceberg that you have mentioned and draw before, and I found it also very, very nicely illustrated that we know there are so many signs and symptoms in children that are the manifestations of really hidden causes and causes that we need to kind of dig out and inform the parent. And once the parent is informed, then a team can work into solving and correcting early. And what I found actually,
Rafif, like you mentioned one point, you mentioned about this genetic factor of class 3 in the Middle East. I want to ask you a very direct, straight question. Would you say that these class 3 cases you've seen are really genetic, or are these class 3 cases retrognathic maxillas, which are caused by low tongue posture and are maybe more epigenetic than genetic? What is your feeling in that?
Hi everyone, I hope you enjoy our Straight Talk. If you want to find out more information about the courses we're offering, they're available on our website, theorthodonticspecialist.co.uk, in our course section. And now we will continue with the podcast. Bye!
I mean, there's definitely like a genetic factor that you know that has to do with it, but it's the percentage of it, you know, I can't point it, but I do know that we do see certain family. There are certain families that I can literally call with names in the region, where you see the whole family, from the grandfather to the parent to the child to the grandchild. You know, you see they are all class 3, but if they are left to the environment and to, you know, without being treated early, you know, they develop into, you know, complete adult, you know, class 3 that are only can be treated, you know, with an orthodontic surgical cases, right? But the fact that we are detecting them super early, and we are able to play on the epigenetics and on the environmental factors, that goes a long way. And that's what I noticed, that, you know, in my, you know, 16 year of career now in pediatric dentistry, I started noticing that our world, or our industry of medicine and of healthcare, is really not designed to solve diseases. The medicine around us today, the whole healthcare system is very centered, you know, around the system and the disease, and is not centered around the patient. And I started implementing a few years ago in my practice more of a patient-centered system, where I really, you know, tailor the treatment plan into my patient. I look at a very comprehensive level at everything. And then that's how I started, you know, incorporating into my questionnaire and questions, you know, diet, breathing patterns, you know, the sleep quality, the history of the family, everything, right? The environment, you know, how's the AC quality in the room, you know, are you doing a duct cleaning, everything. I start really digging into everything, and this is how things have changed.
Because I think this is the interesting point. It's like, even when we have a genetic predisposition of a whole family, where we all know that it's a real class 3, we call it in orthodontics, where the fault is in the lower jaw. But actually, by manipulating growth in very early stages in life, by encouraging the maxilla to develop more than normal and to maybe protract the maxilla, we can maybe eventually avoid double jaw surgery later. But also, I think you will agree with me, the side effects of this narrow upper constricted arch is also with breathing and the issues that come with it: mental health, ADHD, diet, self-esteem. So if you have seen all of these families, I think you have a high value of actually seeing what is the degrading pattern when you don't intercept in these malocclusions as early as you do. What did you experience when you look at all of the families? How do the granddads look? What kind of life did they have? How did they suffer with what they went through? So what is your experience in this matter?
100%. You see, you know, how, you know, they were socially affected. And I've had actually a patient 2 years ago that were like all his father's side were all like true class 3. And I caught him with a crossbite, and he was 6. So he was in an anterior crossbite at 6, right when the upper central incisors, you know, are gonna go. So he was kind of, you know, the central incisors were almost stuck. And that's where I treated him. You know, we did like an expansion of the maxilla, a fixed maxillary expansion. And then this is where the clear aligners were very useful. And this is how I find them useful in my daily practice, that they complement my maxillary expansion sometimes, especially, you know, patients with a class 3 tendency. So, you know, I do a maxillary expansion, I relieve this crossbite, and then I, you know, finish with a phase 1 of clear aligners. And this patient, I followed him up. Now he is, I think, 12 or 11. And he is still in a perfect class 1 occlusion. And so I feel like I've broken the spell, you know, of the family by doing. Now I have parents who come, you know, where the dad is the true class 3, where he was surgically, you know, operated for his class 3, and they come specifically because they don't want, you know, they they saw my cases and they don't want their child to go through the same stress and the same social bullying, a lot of things that can happen as a side effect and consequences. So they are the perfect role models, their fathers, because they don't want them to go through the same thing.
Hi, I hope you're enjoying our straight talk so far. If you're interested in any mentoring or one-on-one session with me to discuss cases or any questions you might have about the treatments of your patients, please reach out to us in our mentor program. We're offering that. We have more information. It's on our website, theorthodonticspecialist.co.uk. And now we're going back to our podcast. Bye.
So what is interesting to me, that you combine already 3D printed metal devices, or maybe lab-made, maybe not quite yet 3D metal printing, but you combine it with aligners. And that is actually also what I teach in my courses. But who told you that? Where do you get it? Because it's so unique, this approach of combining metal printed devices and RMEs with the phase 1 of clear aligners afterwards. Because this concept that you and me are practicing is not well known. So where did you get this knowledge?
It was really like a kind of a self search, I feel like I bumped into a lot of walls before getting there, and even now I feel I'm still learning, on a daily basis, and I still feel like I feel like you just learn from your failures, especially in the orthodontics world and in the early correction. I feel like you really have to fail, somewhere to be able to learn again and adjust and twist and master something. But it was really like following up to my cases and seeing, what did I do here that can be more perfected? Should I catch it more early or later? Because sometimes orthodontics, I feel it's all about timing, because if you lose that momentum, then you're done. And that's what I tell to my patients. I tell them, the earlier you come, the easier things are solved. The earlier you come, I can detect things and we can fix them in such an easy way that can go a long way. When you wait later and they see it, when the child comes at 8 and 9 and I look at it, it's
I think you mentioned a really, really good point there, because I had the same experience. And I think the most important thing as a clinician is that you are transparent with your patients and you tell them when you treat, especially when we talk about class 3 cases now, that you are trying to correct that malocclusion, but you cannot overpromise and the treatment outcome, that you might still need to dentally compensate at a later stage by retracting lower teeth. So basically, it's really important to keep the parents on board in this, and you roll together in that journey, because it's a long time game, and that the parents are always aware of what could happen. And if something happens, if a growth spurt is happening, that you can interact and intercept again. Because like you will say, you've done now an RME in a phase 1, but most likely you will need a phase 2 at a later stage. So this is a long-term commitment, and parents need to be aware of that they are in for a long ride. And that is super important, because initially when I started with clear aligners, for example, I thought I have a magic wand and I swing it around and clear aligners will do everything. But then you will see also within the first course of treatment, you lose a lot of baby teeth and suddenly use all the anchorage, and you have to wait for more teeth to come out, and you lose valuable treatment time, which is lost. And then at the end of your phase 1 with Invisalign, for example, you're stuck and you don't know, you can't do more because you haven't discussed the fee structure yet. So it's really important that we talk openly about it. And we briefly talked yesterday about it between the phases. It's a really important point. What happens after this phase 1? So it comes from a fixed retention in the 4 front teeth to eventually passive aligners. Like what I found is that when you start with this early intervention, I quote them for the whole course of treatment. So I quote them for phase 1 with rapid maxillary expansion with aligners, but also for phase 2, because That way, they have once a fee structure present, and then they know exactly what they buy into. Because you will know as well, if you quote for phase one, sometimes you already automatically you go into phase two because you're already there, and you already done such a great job in phase one that there is no phase two.
True.
So that way, I like to be very transparent in fees, because what I don't want is you do such an amazing job in creating a frontal crossbite, correcting it, aligning teeth, and then you run out of time. You talk about finances again, and it gives a negative feeling because people think, oh, do I need to pay again? And I don't want any negativity in the whole journey of being treated. So with the expansion, do you use rapid maxillary expanders, or do you use already the Invisalign palatal expander, which is now launched, maybe not in Dubai, but in America? What do you think about this new technology that is evolving with direct printed aligners? Where do you see the future is going with that?
I think the future of aligners, and also the future of artificial intelligence in in the technology in dentistry, is really like where I think we are only like flirting with the surface, until now. I think there's a lot to do. Even now, if you see the new iTero scanners and digital scanners, there's so much now AI built in, and intelligence into detecting. Now we have into our digital scanner. Like the visual world is so well developed in dentistry, and it's fascinating. But I think, like anything new, humans and dentists specifically are specific humans that are very resistant to change. So we don't like change a lot. And I think it's like any technology, we need to be, as practitioners, comfortable with using it. And it takes time to master it and be comfortable into the ins and outs. I personally, now what I do is I do my rapid maxillary expansion typically as a fixed appliance first. And I usually finish my expansion if it's needed, and then I pass to aligners. I don't do them simultaneously, because especially that you also have to understand the audience, or your little patients, or from a background or cultural background or community perspective. And here in Dubai, in this region, we deal with a lot of multi backgrounds, multiculturals from all over the world. So sometimes things can be a little bit sensitive. You really want to have them give them a treatment that is also comfortable, and there's also tailored to their daily life. And what an adult can go through, sometimes a child cannot go through. So I try to do it in a gentle way, where they don't feel overwhelmed by too many things. And I try to take that psychology aspect also away from them, because at the end of the day, I want their compliance. I don't want them to be so overwhelmed that and this is what happens when I started using the clear aligners. I also started first with the things that are super overwhelming, and then I gradually took my treatment plans into getting very gentle, and then moving up to the phases where it's a little bit more hard work for the child. And then I kind of learned my way through it. And I think it's something super important to take in consideration when you do aligners or orthodontic treatment in little kids. You really have to also understand what they go through, and do it in a gentle way. Yeah. And what you mentioned a point very, very interesting about the class 3, how do we treat them, and then how to inform the parent that we're going to have to maybe interfere later. And that's what I always do, especially in those cases, because I know that once the growth spur is going to kick, and when the hormones are going to kick, I always tell them we're going to have a growth spur, especially in boys, and then things can go sometimes uncontrolled, and then we have. That's why I really insist to parents and to all my patients that close monitoring is so important, and regular checkups, because it's not just we do something and then we leave. It's really and that's the beauty of pediatric dentistry, and the beauty of my job is that I see my patients every 3 to 6 months all the time, whether they come for orthodontics or not, and we build kind of, you know, we bond, we build a long-term relationship with them, and that helps, that goes a long way.
So I want to pick up on one point with AI, because obviously I agree with you, AI is amazing, but it's also very dangerous in other ways. But for example, there are companies now also with aligners who give you AI technology to analyze a cephalometric, who analyze a pen-oral, and AI might be able to detect also soft tissue problems, like, for example, adenoids, tonsils, constricted airways, and all things. But the problem is still, the most crucial problem is that people, dentists, still have no idea yet how our profession is actually impacted on airway and adenoids. And what we can see in these x-rays, even if AI will flag it up as a problem, we as orthodontists, we need to understand that if we have a constricted airway, and then our treatment plan means we're extracting 4 teeth, that is not the right approach. So AI gives us maybe data, but it's up to us clinicians to use the data and make a treatment plan that is good for the health of these patients. So I just mentioned adenoids, ear infections, tonsils. So these are all symptoms of a problem that you see every day in these children. And you will probably agree with me as well. It's like you feel it's a disease that is out there, not being recognized at all. So what is your experience now in Dubai, in that area? How do kids breathe? Where is their position? What is about infection? What is being done by orthodontists or dentists right now there? How do you feel when you refer a kid for orthodontic treatment? What was your feeling with your colleagues? What is happening in the industry right now?
Yeah, well, when I started investigating into breathing and upper area obstructions and adenoids and tonsils and mouth breathing, I had a big clash with orthodontists working in private clinics and public hospitals, because you know, there's always this book or this Bible of you know, that we kind of learned in dental school, that, you know, you only refer at 8, you know, or at 7, and oh, you only maybe do the treatment all permanent teeth. And then I always clashed with that clause, you know, in the book rules, because I thought that, you know, it's always too late, right? To, you know, instead of treating the, you know, the upstream or the root cause of the problem, why do we want to wait until all the symptoms showed up? And, you know, orthodontics is not about treating the symptoms, it's about treating the root cause and about detecting it early. So I always had this clash in this region when I first came many years ago, and now I feel that things are slowly spreading into now you see more dentists and orthodontists starting early, but we still have this we still have patients coming, and then they're really shocked, you know, when I tell them that we you know, when I talk about mouth breathing, or I detect myself or tonsils, I feel that really parents are shocked, and they're really telling me, oh wow, now the puzzle is like more clear. Now I can link, you know, those points together. How come no one tells me? I've been seeing the pediatrician for 5 years. I've been taking my child to the pediatrician for 4 years now. How come the pediatrician never tells me anything? And even sometimes I'm surprised, because even ENTs, you know, they don't, they tell patients, oh, you know, come back, let's just, you know, monitor this, and then maybe we can do the surgery in a few years. And sometimes I find myself pushing, you know, for a surgical removal of tonsils, or for a proper treatment that, you know, relieve the airway obstruction. And again, the beauty of pediatric dentistry is that you see those kids very early. because our first dental visit, you know, at a pediatric dentist start at 1. So at 1, I'm able to see everything and follow up with the child, especially with the thumb sucking, the tongue thrust. I see them very early. The long or, you know, prolonged use of pacifiers. I'm able to see the sucking pattern, the intensity of sucking in a child. I'm able actually to detect the teeth grinding very, very early, much earlier than orthodontists. So that allows me to refer early to ENTs and to you know, work closely on early correction and hint it to the parents. So I have patients that, you know, were treated very early at 4 and 5 for their you know, for their airway issues. And now parents, they come back for their checkup after 6 months or 1 year, and they tell me, my child has transformed. He's a different child. He's lively. He's energetic. You know, his grades are better. His you know, you really see the difference. And then it's mind.
So look, this is, I think, the one, if we have one take-home message of this whole podcast is, as a pediatric dentist, you are actually have the opportunity, because you see these children as one of the first doctors ever, very early on in life, and you have the opportunity to basically diagnose early problems very, very well. The most problems you have as pediatric dentists, you don't know what to do afterwards. Like, you were at one point in your career at that stage, you've seen these problems, these behavioral issues, the concentration, the crowding, the breathing. You detected all of things. You asked yourself questions and you didn't get the answers. So it's super important that you get education as a pediatric dentist in how to treat it, because I'm an orthodontist and I tell you that unfortunately orthodontists, they focus a lot on teenagers and adults because the system tells them this is what you are supposed to do. But actually the age group below 10 is so much more valuable, and that's where my passion comes in. Like, I would love pediatric dentists to take on this age group. I will train them in this, because if you don't do it, who else is going to do it? And you're already so far ahead in the game that you went on this venture without actually having guidance yourself. You did trial and error, and you failed, and sometimes you succeeded. You took the succession and did something else. But you need to educate, because unfortunately orthodontists are not that far yet to understand that our business should be prevention. Because
Yes.
with aligners, Invisalign pushing on the market and going to the GDP a lot, that a lot of more dentists are conquering the adult market, and now a lot of more dentists are actually treating teenagers. So, but they are all not fixing the problem. They're just putting the fire out when the fire is there. We as preventive orthodontists or pediatric dentists, we can actually make sure that there never be a fire to put out. And this is, I think, the most crucial part we have to play, that you as a pediatric dentist, you have so much power and so much value in the whole preventative system. And I thank you for going on that venture. And you did it already. And you're doing an amazing job. What you know, other people we need to know more about. And I think we should go deeper into these things with ear infections and behavior issues, because we talked about the iceberg. Like, what the symptoms we see is only a small part of the problem. We need to dig deeper. So what was the journey for you? Where did it make click in your head where you think, oh God, this is all linked? How could I have missed it my whole 10 years in my career? Where was this point for you in your career where you think, oh my goodness, this is opening such a big area, which I need to investigate much more time into to make sense in my own head? Because it was for me certainly that way. That's why I do all these podcasts now, because there's so much more than just the teeth.
Yeah, it's true. I think I never had like, you know, like one moment, but I think one of the moments where I really had like, you know, okay, I really need to investigate in that, because I think we were taught in dental school many years ago, because I'm not that young, that teeth grinding in children is normal, you know. And then I started, I think 10 years ago, I started having many parents coming every day. It used to be like almost the main complaint of the day from parents. My child's teeth, you know, my child grinds his teeth at night to a point where I can hear the noise from another room. You know, you always hear this if you work in a pediatric dental clinic. You hear this from a parent at least once a day, you know, within your patients. And then I started realizing, like, I cannot tell my patients that is normal every time. You know, I have to understand what is the root cause of, you know, why this child is. And then I started reading, you know, investigating, you know, and I noticed that, you know, I ended up understanding that teeth grinding in children is really related. It has nothing to do with teeth. It has to do with, you know, breathing patterns, you know, how the quality of sleep. And then I realized that the quality, you know, we're not only treating the bite of a child and the teeth of a child, we're treating his quality of life. And from the moment that a dentist realizes that, you know, his objective is to improve the quality of life of a child, then everything is linked. It becomes really like, you know, a puzzle where, you know, you're treating the headache of a child. I also had a lot of children, you know, many years ago coming, and then the parent is telling me, my child is 7 and he has headaches every day. And then, you know, if they go to another dentist, he would tell them, oh, it's normal. It might, you know, maybe he has changes or stress at school or is having fights. The problems, and I found that, you know, we have bite issues. You know, the bite is dysfunctional. The breathing, the tongue doesn't have the right space in the palate. So when you detect those things and you treat them, I noticed that the headache of the child is disappeared. So I started noticing that I'm actually doing something good. And it's not just, again, about, you know, the aesthetics or, you know, he has spaces between his teeth that I'm aligning. It's really about focusing on the quality of life of a child. That goes a long way. You know, it's better for his, you know, sleep quality, for his focus, you know, their energy level during the day. And then, you know, headaches. We have a lot of children in Dubai that, you know, that are, you know, they have headaches. And then sometimes, you know, fixing their bite or, you know, having a more functional, you know, face correction, then it's treated. And Dubai is one of the most polluted cities today. We have a very polluted city. The humidity levels are you know, to the roof. And then the air conditioning systems are, you know, widely used. So we have a high rate of asthma, we have a high rate of breathing issues in kids. So we have, I think, more bite issues and more dysfunctional, you know, patterns of face growth more than other region of the world. Hence, my, you know, profession is much needed to treat and detect, you know, early those problems.
How would you say if I tell you your kids have ADHD? What would you say to me? Would you agree with me that every kid nowadays nearly has ADHD? Or what is your opinion on this big topic? Because if I look in the UK, we're running even out of medication for ADHD.
Well, I have a very personal opinion about ADHD. My personal opinion is that it's really overrated. You know, I think we put the label of ADHD a bit everywhere these days. But there's a lot of you know, aspects of ADHD that are, you know, that we label ADHD, but they are really root caused in breathing and in mouth breathing. And, you know, the child is not breathing well and it's affecting, you know, his brain development, so on. But also we have, you know, the modern parenting, you know, in today's world, also is producing labels, you know, of ADHD kids that, you know, maybe they are not real ADHD, but you know, they are more distracted, or they have a low short attention span. And this is what we see every day in our practice, because parenting today is very different than parenting 15 years ago. So we are also dealing with a lot of behavior styles of children. I'm dealing every day that is passing with our modern world. I'm dealing with kids with shorter attention span. So I'm kind of forced to do my treatments in a shorter level. I noticed that in the last 10 years, I became you know, a faster pediatric dentist on my chair, because I'm dealing with shorter attention span, and because I feel that, you know, children struggle to focus, you know, not only because of the breathing issues, but because of our modern parenting. You know, we want something fast.
I agree.
Parents
So
want fast.
maybe we should explain the audience the link between breathing and ADHD, because there's plenty of research that by the way we breathe, we can control our nervous system. And when
Yes.
we breathe through our mouth, we talk more to a system that is more the fight and flight system in our nervous system. That means if our children can't breathe properly at night and their mouth is open, that is something you need to look out for. Try lips and mouth open for your children. That they are basically always active, always alert to fight and flight. So they never reach the recovery stage in their sleep. So they're always hyper. And you know, when you have children, we both had twins, if you don't sleep, it's a torture for you. So also, how can we be surprised that our children, when they don't sleep properly, are not recovering well, they can't concentrate well, and they are very hyper at school. We call it attention deficit hyperactivity syndrome. So a lot of these kids maybe have just a breathing problem, and one of the easy ways to solve it is actually maybe tape their mouth. So, so I think it's a really big topic, but I want to go to something completely different. You do a lot of clear liners in kids. What made you choose the device of clear liners compared to what we used to be trained at university with Schwartz expanders, Bionator, Frankel, like all these functional devices we used to be trained in, me especially in Germany. But what made you choose a clear liner in children?
I think it was the combination, you know, the fact that after my expansions, I was able to align, or for example, treat cross bites that I was not able to do with the traditional, you know, appliances that were taught in traditional orthodontics. And I feel also that from a hygiene level, it was also interesting to use them in children, because it's amazing how when I started with the clear aligners, people or parents, I heard a lot of opinions. Oh, you know, he will never wear those aligners. But then what I noticed in my practice after a few years of using them, that actually children are more reliable and more compliant than adults with clear aligners. And I tried the clear aligners myself as an adult. I was not as compliant as my patients, because especially when you treat to 6 to 8 or 6 to 9, you know, the age range, they take it seriously. They take it at heart. You know, I make them sign a contract, you know, between us with all the bullets and at heart. And I've never seen, I honestly have never seen as much, you know, children as compliant as them in my whole career. I see a lot of, and you know, the treatments go super fast with them because they are very committed.
Also, I think a big point we have to mention here is mental health, because a lot of children, they have a certain malocclusion with, they don't look great, they are embarrassed to look in the camera. Now we're in a social media generation where they take selfies. So there's some kids, they reach out to their parents and asking their parents for help with their teeth, with their appearance. And then what's happening in the UK is that the parents go to a dentist or orthodontist at the age of 8, 9, 10 and says, my child is not smiling. It affects their self-confidence. Can you please help her? And they're being bluntly said, no, please wait until she goes in secondary school, and then we can deal with it eventually with extractions. I feel as an ethical responsibility, it's absolutely appalling to deny a kid who's growing in confidence or not this kind of treatment, because also if you look at a bit of statistics, since the iPhone was introduced in 2007, the self-harm rate and suicide rate of teenage girls is increasing rapidly. So
Yes.
as a thing which is really close to my heart, it's not always the malocclusion, what we've been taught by universities, so much crowding, so much overcheck, frostbite here. Sometimes it's just, how is your child feeling? It could be a gap, like one of my patients has been called a slot machine. It could be a protruding front tooth. Whatever it is, it's super important as a pediatric dentist as well. If a patient is concerned about the appearance and you know you have a tool available with a clear aligner to correct that problem for them, it makes a huge impact on the child's life growing a teenager later. I think this is not to forget. And I promise you, like you mentioned as well, every kid who feels like that, they will never not wear this aligner because they have such a high need for this, because they want to feel great, that they will do anything to do that. And this is what got me into prevention as well, is the feedback you receive from your patients is so much more than I ever received from an adult. Because you might just get a hug or thank you or maybe a smile. But when they come back and give you a hug, it comes from the bottom of their heart because they feel that you helped them. And forget everything else we learn. If you can just give the child a bit of a smile in their life, I think that alone is worth doing children with clear lines. And the tool we were given by companies like Angel Aligner, Invisalign, they're actually the only companies who are doing kids. It's a beautiful tool because it's super comfortable. Like you said, it's super discreet. They can throw it on the floor if they want to. It doesn't break. So it was, for me, actually a game changer in the way I was practicing orthodontics. And with the years of experience now and the amount of changes I could achieve, it just fulfills me with so much happiness that any orthodontist out there who might be frustrated in treating adults, dealing with their psychology, they should really think about treating children with clear lines, because you love your profession. I love my profession. And why do we love it so much? Because we can help children.
Yes, and what I also noticed is when I do clear aligners for children, especially in children who are, because sometimes children, they don't express their negative feelings to their parents, you only know later. So what I noticed is that while we were doing the treatment with clear aligners, they came to me at the initial presentation with very poor oral hygiene. So we had to really work hard into, instilling a good hygiene, regular cleaning, so on. And then once the clear aligners are fixed, you notice that even their attitude towards their smile and towards their personal hygiene is different. Towards the children that I treat with clear aligners, towards the middle of the treatment plan, or even the few aligners that they start wearing, you notice that their oral hygiene is much better at home. They are taking much more better care of their hygiene and brushing, and they are even taking care of themselves. They're even taking care of their personal hygiene, of their physical, outfit, of everything. So I'm really noticing even the effect on their confidence boost, on their self-esteem. So it really went a long way.
And I mean, from experience point of view, is also the difference. Like I come from I was trained very holistically in Germany with function device. But then when I went to UK 9 years ago, I was more or less forced on the adult market, which I treated mainly with lingual braces. But about 5 years ago, I came back to pediatric dentists. And if you compare the tools, like I would certainly agree with you. I would treat adults more with lingual braces, to be fair, because of compliance and because adults generally are not very reliable. But every kid I would treat with a clear aligner. The difficulty for me personally is teenagers, because teenagers are, they have their own way, their own hormones are all over the place. And sometimes they're very good and very committed, but sometimes they're actually not. And the parents want them to have treatment, but the kids actually don't care. So for me, actually, the critical point in orthodontics right now is the in between the adults and the young kids. So how do you feel?
100%. Yes. Yeah, I have the same 10. I find below 10 are patients that are very easy to treat. You know, they're flexible, they're reliant, they're compliant. I think the hardest age to treat is the teenagers, like 10 to 14, because they're also very hard. You know, it's very hard to gain their trust. You know, they're already dealing with a lot. They're overwhelmed with, you know, finding their identity. You know, they're dealing with hormones. They're dealing with changes at school. You know, they're in a very critical phase of their life. And orthodontics are very hard to achieve. And also from a growth perspective, what's done is almost done. You know, if the issues are already installed, right? And it's very hard. That's why I love it when a parent comes for a second opinion, for example, for clear aligners with me, and then they told me, oh, you know, my child, I took my child to an orthodontist, and my treatment plan includes extraction. And then I love it because I hate orthodontic treatments that have extraction. I'm all about treating super early, you know, having, you know, making bigger jaws, big jaws, and you know, having enough space to fit everything, you know, and then aligning. I love that because I feel the airways open, you know, the jaws are open. And why, you know, extractions make very ugly facial adults on the long run. You know, they, you know, you get rid of your cheekbones, you get rid of all the life in your face. And now, and what I see now is I see the parents complaining. The parents come to me and they tell me, oh, I had braces with extractions when I was a child, and the reason I'm here is because I don't want my child to have the same, because, you know, I see my face now and I don't like it.
So I want to ask you a question. You are a pediatric dentist. Hopefully a lot of pediatric dentists will listen to this. What is it you look out for when you see your children? Apart from now, of course, they're checking dental fitness and the tooth, the teeth, the gums, but what are actually the signs and symptoms you look in your consultation out for in children? What is it? If you can bullet point some key things you always check.
I look at if the lips are, I ask a lot of questions to parents. One of the questions I ask is the vitamin D levels. Another question I ask.
Why do you ask about vitamin D?
So vitamin D is very, very linked to cavities in children and to also the development of jaws. So studies show that kids deficient in vitamin have smaller jaws and more crowded teeth. So what I want to make sure of is that when I'm treating a child, I want to also make sure that, you know, the homework is being done well at home. So that's why I review the diet of the child. That's super important. I review if they eat a balanced diet, and especially if they incorporate animal protein, because again, studies show that animal protein and having a functional chewing diet pattern also affect, can cause, the deficiency of that can cause smaller jaws, hypo maxillas, and crowded teeth. So I find as a pediatric dentist, those are like very crucial elements to go through, not only just the teeth, but also see what's going on at home. What are, are the parents vegetarian? Are they, is the child having enough the vitamin D? Is his diet balanced? Is he chewing? A lot of kids also in Dubai, what I see, have sensory issues with food. They are really based on a soft diet. They only have chicken nuggets and pasta and rice, and you see more cavities in those children and smaller jaws. So what I try to do is, even sometimes I refer them to sensory specialists, sensory feeding specialists, and they work on their feeding patterns. And sometimes we succeed in converting those patients into children who chew better, who eat a variety of food. And we also see a good positive effect on teeth, on cavities, and also on the plaque. Even now I got to a stage, even when I look at the quality of the plaque, I can tell what the child eats. So it's fascinating. But other bullets that are very important to look at for a child is mouth. Does he seal his lips, during his day activity, during his daytime conscious, activity? Or is he the type of child that, he would sit watching TV and he would be like, his lips are always open, he has like this, long face syndrome while he's watching TV or playing, or, on his iPad or doing his homework. Those are red flags that a dentist should look at and ask, because those are the triggers, to mouth breathing, to maybe the presence of adenoids, to vegetations, to tonsils, and then, tackle them one by one. Yeah.
So if I can add some things now.
Yes.
So, because obviously diet absolutely, James Nestor in his book Breathe talks a lot about when did it all start with the food introduction of soft diet and all of these things. So I think absolutely diet is a crucial part in the development of children. And Pedro Planas actually in 1960 already said that we need stimulus. So in order for stimulus, we need to use the things that stimulate the jaw development, which is muscles. So it actually starts already as early as breastfeeding.
Yes.
So because if we can't breastfeed well, it could be related to tongue tie or tongue restrictions. So for the young moms out there, it's super important that we encourage moms to breastfeed, because it will stimulate the muscle structure much more, up to 60 times more than non-breastfed children, which is again stimulus for natural growth. So it's diet, early diet, and hard diet, not all this soft diet. It's breastfeeding, yeah, and then consistently use chewing muscles and not the soft diet. So we need to use both sides to chew on, to allow symmetric growth and symmetric stimulus of the other. But the most crucial part is as well the tongue resting position, which should be in the palate with the lips sealed, like you mentioned already, and nose breathing. So at this point, I need to ask you, do you do myobrace?
I do myofunctional therapy, but I find it the most successful when it's combined with all the other techniques, because I think alone, alone it has its limits. So that's why, for a patient who is tongue thrusting, who had the thumb sucking pattern, who had the thumb sucking happen for many, many years. I see a lot of kids who, thumb sucked for a very long time, up with a tongue thrust and a narrow palate. At the end of the day, even if I train his tongue for 2 years and there's not enough space in his palate for his tongue to rest, then you hit a wall. So I think a proper expansion when it's needed, coupled by myofunctional therapy, coupled sometimes by speech therapy, coupled with an airway correction. I think it's dentists, we are a bit like, like a one-man show where we have we open our bag and we have so many tools, and for every patient we have to pick, we have to select a certain X number of tools that we have to use, but it's never one thing, so I always, whenever a new technology or a new brand comes to my clinic and then they want to sell me something, I always tell them, it's however you want, but at the end of the day, it's only a tool. It's only a tool in the hands of the dentist, and we have to pick the right tool and the right timing. And sometimes we need more than one tool, because sometimes you have brands coming, with myofunctional therapy and this and that, but it's never about the tool.
I honestly, it could have been said by me, because when I teach my students, we have to understand a clear line is only one tool of many tools in our toolbox. And we need, the most important thing is that we need like-minded people in our team, where every team member is specialized on something else, but we overall look at the patient together. So I totally agree. MyoPraise, the philosophy of that is that we control the muscle structures around the teeth, and the teeth will adapt to that function. The problem with that is, number one, we need a compliant patient who does exercises consistently.
Yes.
Number two, it takes time. And nowadays in our modern world, in Dubai, it's the same as in London, people want to see immediate results. So that is why I totally agree. Myofunctional device like MyoPraise is amazing, but in combination with active devices like a clear liner to actually move these teeth quickly, to create spaces for tongue and airway quickly, because that way we can see results, and that way we can also motivate patients. So
Yes.
I totally agree with you. You need a team of all these disciplines: speech therapy, osteopathy, psychologist, pediatrician, dietitian, GP. There's so many people. So actually, like I always say, my dream would be to have a center in Dubai, maybe, of all the parties in all one building. And then in the morning, you meet together and discuss a case together from all the different aspects. So
yes, and what I also use is an appliance. I don't want to talk about a lot about brands now. It is called Froggy Mouth. Have you ever seen it?
Yeah, of course.
Yeah. So and then what I also do, I had to learn also about tongue exercises and speech therapy, and sometimes I even incorporate them into my treatment plans, and I send them in parallel for the child in like little videos to practice them. But you can there's so many tools, and then you have to couple them, and then again you need the child to be compliant and understand the why why he's doing this. And I think also educating our patients and our parents is so important, because you really want them to understand why they are doing what we're asking them to do.
I mean, I think agree. I think it's wrong for us to say that we are experts in every field, because you cannot be an expert in myofunction, in dentistry, in airway, in orthodontics. I think everyone should be an expert in their own way. And it's about sharing the team and sharing the workload to get the right people on board. But I'm tempting to ask you that last question. In the background, you have this amazing book. Number
Yes.
one, what is this book about? And what made you write the book? You have your mom of children. When do you do all this?
Yeah, I get asked this question a lot, actually. I actually wrote it during my pregnancy. While I was pregnant, I was working full time and I was writing. Actually, this book is a children's book that is aimed, to the ages, between maybe 2, 3, and 8. And it's actually named by my twins. My twins are called Danny and Sarah. So it's called Danny and Sarah Go to Dr. Smile. And what I've noticed during my career in pediatric dentistry, that often the child comes with a dental phobia or with a negative preconception or of the dental visit that is a bit unconsciously transmitted by his parent or by his caregiver or by something that he heard. And often in pediatric dentistry, we have jokes like, please, parents, don't threaten your child, by the dentist. Don't tell your child, oh, if you don't do this, I'm going to take you to the dentist and he's going to, give you the injection. So what I noticed is that there's a lot to do at home before coming to the dentist that prepares a child to a positive attitude towards his dentist. And I found that maybe writing a book that tells a positive experience or positive journey from A to Z, from the time the parent takes an appointment until the time a child leaves with a smile and with a picture. Usually my patients, we take a picture and we put it on the wall of fame of the clinic. I found that very, it really built a positive image. So basically that book is the journey of a first dental visit of a child, and then it's illustrated by an award-winning illustrator that I really liked working with. It's all handly. It's a replica of a dental visit of my patients with me, basically. Yes, and Danny and Sarah were part of that because I wanted to also narrate it or tell the story from a child perspective. So my twins were actually kind of did it in their own words, and because they were also my patients.
So if you could write a book about this last hour, about the things that people don't know yet, how would the storyline be?
It would be Danny and Sarah learn how to breathe.
And the thing is, I think, and Essie, thank you so much for your time. I think, honestly, I feel very strongly about the need for pediatric dentists to learn what you have learned. I can only be here as a support. I can give you the education on it. I think we definitely need to do something together, either in Dubai or here in UK. I think it's amazing what you do. It's a hard struggle maybe because you might have people who completely disagree with what you do. They might be jealous. They might be threatened by what you do. But I know this, but you need to keep going. You're great. You're amazing mom, definitely. You're amazing author. You're amazing dentist. So thank you so much for your time. And I hope we could learn a bit something today with our talk. Thank you so much for your time.
Thank you so much, Dr. Steven, for having me. It was a pleasure and an honor. And I think we need many more orthodontists like you who can, take the child from a very early age and on all those aspects. And I think the perfect combination, I always said that the perfect combination for oral healthcare would be a pediatric dentist and an orthodontist, because I think they kind of cover everything and they catch everything early, so that we don't have to deal with anything, when they're teenagers. So I think,
Was that a job application?
maybe that would be the dream one day.
Was that a job application?
Yeah. Well,
No,
you have to come to Dubai and build something here.
Well, never say never.
Yeah.
Thank you so much. And I don't want to take up too much time because it's late evening for you. You need to go to bed. Thank you so much.
Pleasure.
Take care. Have a nice evening.
Thank you so much. Bye-bye.
Bye.